And for beginning, I would like to thank you for being here, for giving us a presentation. And I'm pretty sure that we're gonna learn a lot of you. So thank you so much, Doctor. The presentation is all yours.
Okay, thank you very much for the presentation, and let's gonna begin, okay? Okay, guys, I'm gonna share my screen. Please let me know if you can see it. Okay, we're all done, right?
Yes, we can watch the presentation.
Perfect. So, okay, guys, as you see, today we're going to be talking about the newborn respiratory disorders. So first of all, I want to introduce myself to make this more enjoyable. So I'm Dr. Raquel Alfaro. At the moment, I'm doing my social service in the maternal and fetal laboratory from the University of Guadalajara. In a few months, actually on September, I will presenting my NARM, the medical exam for the residents. So yes, hopefully, if you wish me luck, I will be doing the pediatrics residence on March. So as you see, I'm very passionate about pediatrics, and these topics are a thing that I really enjoy to talk about. So the objective of this class is to make you feel free to make all your questions, to participate and enjoy this class, which is focused on very basics and general knowledge of the newborn respiratory disorders. So I'm not going to get deep in topics. The main objective of this class is to make a differential diagnosis in a newborn with respiratory distress. So also, as you see, we need to promote the second language, which in this case will be the English. So I know my English is not quite the best, but if I'm not being clear with something, please let me know, and I will try to explain myself better, okay? So let's get this started. So for this presentation, I'm gonna need you to scan the QR code that I'm showing in this side of the screen, the right side. Please scan the QR code. I can see who is in there. So please, if you can scan the QR code, join at slido.com, and you can put the hashtag or the pin that is 623608. Okay, I will give you a few minutes to scan the QR code. Okay, here is the hashtags, the code for the person that is not able to scan the QR code. Okay, I will give you 1 minute more, please. Okay, we're gonna start, right? So to begin with, we need to know the normal fetal to newborn lungs transition, okay? Because respiratory distress is common immediately after birth, and it's typically caused by abnormal respiratory function during transition from fetal to neonatal life. So neonatal respiratory distress may be transient. However, persistent distress requires a rational diagnosis and therapeutic approach to optimize outcome and minimize morbidity, okay? The successful transition from fetal to neonatal life requires a rational diagnosis. The successful transition from fetal to neonatal life at delivery requires a series of rapid physiological changes of the cardiorespiratory system. So this change results in redirection of gas exchange from the placenta to the lung, and as we can see in this picture. So as you see in these pictures, this transition is really complex, but we can simplify it in 3 principal change. Okay, the first change is the replacement of alveolar fluid with air. Okay, as we can see in this picture, in fetal life, the alveolus, as we remember, is full of amniotic fluid. But then when the first inspiration of the newborn, it replaced with air. Then the second change the newborn needs to make is the onset of regular breathing. As we can see in this picture, we have in here a newborn cyanotic. And in the right picture, we have our newborn pink, okay? He is already onset his regular breathing. So this is our second change in this transition from fetal to neonatal life. And then the last one, the third one, is an increase in pulmonary blood flow as a result of an increased systemic vascular resistance, as we can see over here, and a decreased pulmonary vascular resistance. So this is our third change. And then I put it again over here. Our first change is going to be the replacement alveolar fluid with air, the onset of regular breathing, and the increase in pulmonary blood flow. So all of these changes occur in the first minute of life, okay? So this process results in an increase of neonatal artery oxygen tension from 25 milligrams of mercury to 60 or 80 milligrams of mercury, okay? So all of this occurs in 1 minute. This is why it's very important to diagnose this respiratory distress in the newborn. So why it's important to talk about the respiratory distress in the newborn? We're all going to be in some point in contact with newborns as general doctors or whatever. And what we are going to have is this. Please, I want you to see that video over here. And please tell me, I'm gonna put a slide of slides, some differential diagnosis, okay? Please saw this video. I want you to see this video. Put many attention in all the signs. Okay, let me fix this. Okay, let's continue. Sorry about that. So you saw the video, right? I want you to please join the Slido and please write it on some differential diagnosis that you can say that these all newborns could present. If you hasn't scanned the QR code, please scan it. It's over here in the left side, or join directly at slido.com, okay? And please write some differential diagnosis.
Doctor, the screen has stopped in the video. I don't know if you can, yeah, now we can watch it.
Okay, okay. Okay, we have your answers over here. Transient tachypnea of the newborn, pneumothorax, irregular breathing, meconium aspiration. What else? Pneumonia, someone says over here. What else is in your mind that all of these newborns could have? Okay, so the video that you saw, it's gonna be our clinical presentation in all the pathologies. So we need to be very meticulous in identifying certain clues in order to get to our diagnosis, right? As you see, there are many diagnoses that this baby could have. It could be congenital diaphragmatic hernia, congenital pneumonia, puanal atresia, spontaneous pneumothorax, Yelling membrane disease, transient tachypnea of the newborn, meconium aspiration syndrome, etc. So all of the pathologies we're gonna see in this webinar are present like this video, okay? So we're gonna talk about in this class like one scale that is very important that you just saw in this video, and it's very important to evaluate in all of our newborns, okay? This is called the Silverman-Anderson retraction score. It's a very important scale that we need to use to evaluate our newborns to see if they're having respiratory distress, okay? This scale consists in all of this. It evaluates 5 points, okay? The upper chest movement, the lower chest retraction, the xiphoid retraction, nares dilatation, and expiratory grunt. So it gives 0 points, 1 point, or 2 points of each one, okay? As we can see over here, we have chest movement, and the Silverman-Anderson's score gives 0 points for synchronized respirations, 1 point for lagging respiration, and 2 points for seesaw respiration. It's a dissociation for thorax and abdomen, okay? Then we have intercostal retractions. Silverman scale give 0 points for none, 1 point for just visible, and 2 points for marked. Then we have xiphoid retractions, 0 points for none, 1 point for just visible, and 2 points for mark. Then nares dilatations, 0 points for none, 1 point for minimal, and 2 points for mark. And the last one is the expiratory grunt. Silverman scales gives 0 points for none, 1 point for audible by stethoscope, and 2 points for audible just by ear, okay? So this is a scale that you need to know, you need to remember, and you need to recognize in a newborn. And in order to get the diagnosis of the respiratory distress, we have that Silverman scales give, if you have in a newborn 1 to 3 points, you're gonna have a mild respiratory distress. If you get a score of 4 to 6, it's a moderate respiratory distress. If you have a score of 7 to 10, you have a severe respiratory distress. So as you see, the maximum of points that you have in a Silverman scale are going to be 10, and it is going to be the worst. And the minimum is going to be 0, a normal newborn, okay? So in which time do we evaluate this Silverman scale in a newborn? At 10 minutes, okay? At 10 minutes of birth, at 10 minutes of the delivery of the newborn, we're gonna need to evaluate this scale in all of our newborns, okay? So other two signs that are very important in a newborn is cyanosis on room air. As we can see over here with this neonate, he has cyanosis, and this other one has acrocyanosis, okay? This is gonna be a very important signs too. And other important sign we need to evaluate in our newborn, and we need to be very meticulous, is tachypnea, okay? We need to remember that in the adult, tachypnea is defined by 18 to 20 respirations per minute. In the newborn, it's completely different. We consider tachypnea from a respiration per minute above 16, okay? Above 60, we consider tachypnea. So a clue that I really want you to give you is that a cyanosis, and it's our first clue to need to know, is that cyanosis that doesn't respond to supplemental oxygen is likely a pulmonary hypertension, okay? A persistent pulmonary hypertension or cyanotic congenital heart defect. So always remember these clues. If you give oxygen to a newborn and doesn't respond, you need to suspect in a persistent pulmonary hypertension or cyanotic congenital heart defect. So we're gonna begin with our clinical cases that I will need you to answer in the slide. First, I'm gonna read it to you. We have a newborn female of 38 weeks of gestation, born by elective cesarean that begins at 8 hours of life while remaining in maternity unit with progressive respiratory distress. It presents to examination regular general state without cyanosis, with normal capillary refi, tachypnea, subcostal retraction, nasal flaring, and whining. It corresponds to a Silverman of 4. Presenting a cardiorespiratory auscultation with good bilateral air entry with expiratory sibilance. A chest X-ray shows scisoritis, symmetric perilear congestion, and rectification of the costal arch, okay? And the question is, what is the most likely diagnosis? A, respiratory distress syndrome, transient tachypnea of the newborn, pulmonary dysplasia, or perinatal pneumonia. So go to your Slido and answer, please. Okay, keep answering it. Perfect, let's show the results. If anyone is having problems with the Slido, please let me know. So as we can see over here, 61% of you respond correctly, okay? This newborn has a transient tachypnea of the newborn, okay? What are our keywords over here in this clinical case? Which of these is our clues? Okay, our keywords in this clinical case are 38 weeks of gestation. He was born by cesarean. He has tachypnea and he has scisoritis, okay? These are our keywords as we're gonna see later. So please answer on the slide. What is the etiopathogenesis of this disorder? Intrapartum gram-negative contamination, decrease in pulmonary reabsorption fluid, surfactant deficiency, or increase in vascular resistance. Go to your Slido and answer, please. Don't be afraid to get it wrong. We are here to learn. Okay. Keep answer. Perfect. Okay, so 50% of you got it right. We're gonna see the pathogenesis. So the correct answer was decrease in pulmonary reabsorption fluid, okay? Transient tachypnea of the newborn is the most commonly diagnosed respiratory condition in a term newborn infant, okay? This is a keyword, a term newborn infant. So this condition is also called respiratory distress syndrome type 2, okay? You really need to know this because there is a respiratory distress syndrome type 1. So this condition is caused by a failure of adequate lungs fluid clearance at birth, resulting in an excess lung liquid. So it's a self-limiting condition of the term or near term neonate, lasting like about 24 to 48 hours, and occasionally up to 72 hours. It is not a true disease, but it's a condition caused by retained fetal pulmonary fluid, okay? As we can see in this picture. So despite the common occurrence of retaining lung fluid, the exact mechanism and pathophysiology of this pathology haven't not been well explained, but epithelial ion transport dysfunction in retained lung fluid and the delay in transition of the epithelium from a chloride secreting, as we can see in this picture, and the sodium absorbing is the main physiopathology, okay? A retain of fluid. So please answer the next question. Is the same newborn the same clinical case? But in this case, the question is, which is the main risk factor presented in this case? Is because he's a female, she is 38 weeks of gestation, elective cesarean, or 8 hours of life? Okay. Okay, 60% of you answer it right. Okay, the right answer is elective cesarean, okay? Okay, and here we got the risk factors. In this case, the main risk factor is the cesarean birth, okay? Other risk factors that our newborns could present is precipitated birth, term or near term, perinatal asphyxia, and macrosomy, okay? The risk factors that our mothers could present for this condition is asthma, diabetes, smoking, treated with plenty of fluids, prolonged sedation, and rupture of membranes, okay? This condition usually occurs within 2 hours after delivery, okay? The key word in here is a respiratory rate above 60 respiration per minute, okay? Always remember this. This is gonna be our main clinical presentation. So the onset of tachypnea, transient tachypnea of the newborn usually presents within 2 hours after delivery, and is the tachypnea, as I say to you, is the most prominent feature, okay? Affected infants also may have increase in word of breathing, as we saw on the video later. So you will have an increased word of breathing. Signs of respiratory distress are generally mild and often resolve more quickly than tachypnea, okay? The tachypnea usually is persistent and prolongs more. So cyanosis may be present also, and it usually correct with low concentration of oxygen, okay? Okay. Very important to identify in our chest X-ray, because with this, we could make our differential diagnosis with the other disorders we're gonna see, okay? So the X-ray is gonna be a useful diagnosis that we could use. So the typical chest X-ray findings that we could have in this disorder in transient tachypnea of the newborn has been described in retaining lung fluid. And this is one, the prominent perilear markings of streaking. Two, a mild to moderate hyperaeration. And how can we describe this hyperaeration? We're gonna see a wide intercostal spaces, as we can see in the imaging. Okay, can you see my board? Okay, we're gonna see wide intercostal spaces, as we can see here. Then another signs of hyperaeration. Okay, it's gonna be flattened diaphragms, pulmonary hyperclarity, and rectification of the rib arches, okay? As we can see here, there is not an arch. It's totally rectified. Also, we're gonna see in our X-ray fluid visible in the fissures, and this is called scissoritis. This is the most important site that you need to identify in these newborns, the scissoritis, okay? The fluid visibles in the fissures between the lobes of the lungs lobes, okay? And another signs that you can see in the chest X-ray is an apparent cardiomegaly, okay? As we can see in these pictures, this is what I was saying to you, the scissoritis, okay? Is fluid between the lungs. So it's the most important sign in the chest X-ray. Another picture too, with scissoritis. And we're gonna continue with our clinical case, okay? It's the same newborn, the same clinical case, but what I want you to answer me is, what is the treatment of choice in this newborn? Is it CPAP? Is it mechanical ventilation, inhaled nitric oxide, or oxygen therapy? Okay, go to your Slido and answer, please. Okay, for the ones that just have joined the webinar, you can scan the QR in the left side or join directly at slido.com and put the pin over there. That is 623608, okay? Perfect, so 57% of you answer it right, okay? So because transient tachypnea of the newborn is a self-limited condition, management is supportive, okay? It includes maintaining neutral thermal environment, providing nutrition, and if need, supplemental oxygen, okay? Supplemental oxygen is provided by hood or by nasal cannula, as we can see in this newborn, okay? So what we're gonna need in this newborn is to maintain above 88% of oxygen saturation, okay? It's gonna be 88% our goal, okay? I put it over here, an algorithm that resumes really well the treatment of this disease. Okay, so you need to start the oxygen supplementation about 40% or as necessary to maintain 88 to 95 oxygen saturation in a newborn. If he is not answering to our treatment, and it has a oxygen saturation below 88%, you need to monitor your respiratory until remission of tachypnea. And if you have an oxygen saturation to 88 to 95%, you need to consider starting CPAP, okay? What does CPAP is? It's a nasal continuous positive airway pressure, okay? So this is a treatment in these newborns in a very summarized and simple way. Supplemental oxygen or CPAP in more severe cases, okay? Let's go to our clinical case number 2, and I will give you a few minutes to read it and to focus on it and answer, please. I will give you 1 minute, okay? Okay, let's move on. Which cell secretes the surfactant factor? Type 1 pneumocytes, type 2 pneumocytes, bronchial epithelium, or Langerhans cells? Perfect. So 71% of you answered type 2 pneumocytes, okay? Then the next question is, what is the main function of the surfactant factor? Decrease surface tension, which prevents alveolar collapse, protect alveolar epithelial surface from oxidative damage, accelerate the elimination of alveolar fluid, or decrease the rate of breathing. Please answer. Okay, so the correct answer is decreased surface tension, which prevents alveolar collapse. Okay, and the last question is, it is a radiological data stage number 3, okay? Total absence of pulmonary air, very fine reticular granular image, the cardiac siluette and limits of the hemidiaphragms are not distinguished, greater visibility of a bronchogram, second and third order bronchi can already be seen. Please answer. Perfect. So the correct answer is the cardiac silhouette and limits of the hemidiaphragms are not distinguished. All of these questions, we're gonna see it right ahead, okay? So let's move on with our second disorder in these newborns, that it's gonna be the respiratory distress syndrome type 1, okay? Type 1. It is also called Yalin membrane disease. And this condition is seen primarily in preterm. This is our key clue. The preterm infants do a deficiency or surfactant factor in the lungs, okay? As you see in this picture, we have a preterm newborn, and as we can see below this picture, the weeks of gestation is going to include really well, okay? So this condition, it's going to present mostly in preterm infants. It's not a rule, but it's the most common, okay? Okay, other risk factors that these newborns could have is hypothermia, perinatal asphyxia, diabetic fetopathy, no antenatal corticosteroids, and the male sex. So respiratory disease syndrome is caused by this deficiency of surfactant factor that reduce this alveolar surface tension, which decrease the pressure needed to keep the alveoli inflated, okay, and maintain alveolar stability. So to understand this better, I put you here a balloon, okay? It's like a balloon. Usually we have trouble when we start to inflate the balloon because it collapses and we need to overcome that pressure to open the balloon. So if the balloon has or will have a surfactant, it will be in charge of allowing it to be easily to inflate it and prevents the collapse of the balloon. So it's the same with the lungs, it's the same with the alveoli, okay? When surfactant is deficient, the infant may not be able to generate the increase inspiratory pressure needed to inflate alveolar units. So this will result in development of alveolar or atelectasis, okay? So as we can see in these pictures, our alveoli will be collapsed if there is no surfactant factor, okay? And we will have atelectasis. So what atelectasis is an alveolo collapsed, okay? So reduced surfactant factor results in increased respiratory effort required to expand the lung with each breath, an increased likelihood of alveolar collapse and then of the expiration. So another important thing that you need to know is that pulmonary surfactant factors starts its production at 24 to 34 weeks of gestation, okay? This is the reason why this disorder is most common seen in premature newborns. So the composition of the surfactant factor is other thing that you need to know. And the surfactant factor is composed with mostly phospholipids, okay? 70 to 80%, it's gonna be phospholipids. So then we have a 10% of proteins and 10% of lipids. Other thing very important, and what I asked you before, is which cells makes this surfactant factor, okay? And this is a type 2 pneumocystis. People really like to ask these questions: what type of pneumocystis produce surfactant factor? And it's type 2, okay? This is again the composition of surfactant factors. Mostly we have the composition of phospholipids, then 10% proteins, 10% lipids. And something that many people likes to ask to you and that you really need to know is the main composition. What phospholipid is the most prominent, okay? So this is the dipalmitoyl phosphatidylcholine. This is our most prominent phospholipid in the surfactant factor. So if anyone asks to you which is the main composition of surfactant factor, you need to respond this: dipalmitoyl phosphatidylcholine. Then the most prominent protein that surfactant factor has is surfactant proteins type B, okay? And the most prominent lipid in surfactant factor is cholesterol. Okay, we're gonna continue with an extra point, okay? For each correct answer that you have, you will getting points, and at the end of the webinar, at the end of the presentation, it will be a winner, okay? So please join the quiz. The names will appear on the screen. And the question is, which of these is a prophylactic measure in a probable case of preterm delivery? Please join the quiz and answer the question, please. Okay, we have Jasmine over here, Jaemi, LG. Okay, Jesus, Pablo, Val. Okay, let's go ahead. Which of these is a prophylactic measure in a probable case of preterm delivery? You have 12 seconds, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, 0. Okay. All of you got it right. And we have in first place LG, okay? The next question is, and I want you to pay quiet attention in this question. You need to read really clear your answer. Okay, get ready. And answer it, please. You have 12, 11, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, 0. Okay. This is why I told to you that read really clear your answer, to pay many attention, because the correct answer, so it's dexamethasone or betamethasone, okay? No, both of them. Betamethasone, 12 milligrams intramuscular every 24 hours, 2 doses, or dexamethasone, 6 milligrams intramuscular every 12 hours. It's gonna be 4 doses in total, okay? So I put you over here, the ACOG guide, the American College of Obstetricians and Gynecologists. And what they recommend is an antenatal corticosteroid therapy for for fetal maturation, okay? They recommend a single course of corticosteroids for pregnant women between 24 weeks and 34 weeks of gestation who are at risk of preterm delivery within 7 days. So again, it's betamethasone or dexamethasone, okay? Okay, what else are we gonna have in these newborns with respiratory distress syndrome? The clinical presentation is gonna be respiratory distress, as I say you before, evaluated with the Silverman scale, and it's gonna present at or soon after birth, okay? We're gonna also have cyanosis and polypnea. So also we need to take blood gases from these newborns, and what we're gonna present is hypoxemia or oxygen requirement to maintain the pressure of oxygen above 50 milligrams of mercury, okay? In our X-ray, very important to make the differential diagnosis, we're gonna have a discrete opacity, the reticulogranular pattern, you need to remember this word, and air bronchograms. What is a bronchogram? Is an overpose of the bronchium from the alveoli that is collapsed, okay? And another pattern, very characteristic, that is the ground glass, okay? You need to remember the ground glass. And we're gonna have over here some stages of the X-ray findings. So we're gonna have 4 stages. The stage 1 corresponds to a fine homogeneous ground glass shadowing. The stage 2 corresponds to a bilateral widespread air bronchogram. The stage 3 corresponds to a confluent alveolar shadowing. And the stage 4 corresponds to an alveolar shadowing obscuring cardiac borders. So we have over here the chest array And we can see over here the perceived lung transparency, the fine reticular gland imaging, and a very discrete bronchogram that doesn't exceed the heart silhouette, okay? If the bronchus goes through the atelectacy, we're gonna have a bronchogram, okay? Then we have in the stage 2, a moderate respiratory distress syndromes in which we can have reduced lung transparency, bronchogram exceed the cardiac silhouette, and the reticular granular image extends through the parenchyma, through all the lung parenchyma, okay? Then we're gonna have the stage 3 that corresponds to a severe form of respiratory distress syndromes. And the main characteristic of this stage is the blurry diaphragm and heart, okay? As we can see in these pictures, we're not able to distinguish the cardiac silhouette or the diaphragm. And the last one, the worst of all of the stages in the respiratory distress syndrome is stage 4, that corresponds to a very severe form of respiratory distress syndrome. And we're gonna have in this stage is a white lung. As you can see in this picture, is all of the lung, all of them white, okay? So I want you to choose a stage for each of the following X-rays and to order them, okay? I put here some images of newborns with type 1 respiratory distress syndrome. And what I want you to do is to list the stages in order. For example, the number 1 corresponds to which stage, the number 2, then for which stage corresponds, then the number 3 and 4, okay? Okay, I will give you 10 seconds. Okay. Perfect. Most of you correct answer right. So in this picture, the number 1, we have a stage 1 respiratory distress syndrome. In the number 2, we have a stage 4. You can see all of the lung white. In the number 3, it's a stage 2. And in the number 4 is the stage 3 or respiratory distress syndrome, okay? You need to recognize these patterns. You need to recognize this chest X-ray on these newborns, okay? Because it's gonna include on the treatment. So what is gonna be the treatment in these newborns? In a summarized ways, we're gonna have, if our newborn has a strong respiratory drive, our first choice of treatment gonna be CPAP. But if our newborn is apneic or poor respiratory effort, he has a respiration below 100 beats per minute, we're gonna need back mask ventilation or intubation and invasive ventilation, okay? So I put you over here an algorithm of treatment that says that in a newborn with an acute respiratory distress syndromes, the main thing you're gonna need is CPAP, okay? Then if he sustained respiratory effort and the VO2 is below 0.4, we only need to continue with CPAP. That is our main treatment in this newborn. But if our newborn is on apnea or need a VO2 above 0.4%, you need to intubate this newborn and to administer surfactant therapy, okay? Also, as I said you before, you need to obtain arterial blood gases, and it's going to include in the treatment, okay? If the pH of the newborn is above 7.2, you need only rapid extubation to CPAP, to continue the CPAP, or if your newborn needs or has a pH below 7.2, you need to administer surfactant and to intubate your newborn, okay? So in a simple way, CPAP is our main treatment, but if our newborn is apneic or has a more severe respiratory distress syndrome, you need to make an invasive ventilation. This is our premature, our classic newborn premature with his CPAP, okay? The main treatment in this condition. Then, as I said you before, the main physiopathology of this condition is the deficiency of surfactant, right? So you need to administer surfactant in some of the cases. So you need to administer a surfactant factor if there is an inadequate response to non-invasive respiratory support. And what do we consider an inadequate response? We consider if the neonate requires a PO2 above 0.3 to 0.4% to achieve a target oxygen saturation above 90% while receiving CPAP, okay? Another condition is that he's an apnea, he has an pH, as I said you before, below 7.2, etc. So you need surfactant factor in this condition. And there are plenty of surfactant factor products, but the ones that are the most recommended are the natural ones, okay? And the main choice of all of these natural surfactant factor is poractant alpha, the first one, okay? The Curosurf. So Curosurf is a phospholipid fraction from porcine lung and is the main surfactant factor that we use in Mexico. So how do we administer this surfactant factor in our newborn? Some of the guys mention different ways to administer, but the most commonly technique to administer this surfactant factor is the insure technique, okay? And what is an insure technique? It consists in intubation, surfactant, and rapid extubation, okay? And oral intubation, clinical evaluation of the tube position, surfactant administration, one bolus, generally of 100 to 200 milligrams per kilo, or Curosurf, and then we need to rapid extubation or our newborn, okay? And then continue with CPAP. That is our main treatment in this condition again. I put you over here a resume that you can make screenshot or whatever. And we're gonna pass to our final clinical case. So this is a newborn female of a mother with group and factor O positive and chronic hypertension. She was born at 4 weeks of gestation by cesarean section performed due to cephalopelvic disproportion, meconium stained amniotic fluid, premature rupture of membranes of 4 hours, Apgar 3.7, and birth weight 4.2 kilograms, required resuscitation maneuvers in the cesarean room, and is transferred to neonatology with mechanical ventilation. So the question is, which is the most likely diagnosis, okay? Please answer in your Slido. Respiratory distress syndrome, transient tachypnea of the newborn, meconium aspiration syndrome, or perinatal pneumonia. Okay, all of you answer it right. So our key words in this clinical case is 40 weeks of gestation, meconium stained amniotic fluid, Apgar 3.7, and a birth weight of 4.2 kilograms, okay? This is our keyword, this is our clues in this clinical case. Then the next question is, what is the main physiopathology in this disorder? Lack of lung expansion, decreased pulmonary fluid reabsorption, partial or total occlusion of terminal airways and air sacs, or increased bronchial secretions? Please go to your slide and answer it. Okay. Perfect. The correct answer is a partial or total occlusion of terminal airways and air sacs, okay? And the last one is, which is the main complication of this disease? Sepsis, pleural effusion, polyglobulia, or persistent pulmonary hypertension. Okay, 5 seconds. 4, 3, 2, 1. Okay. You have more doubts in this question, okay? So we're gonna see it quite ahead. So the last of our clinical disorders we're gonna see in this webinar is meconial aspiration syndrome, okay? Meconial aspiration syndrome is defined as a respiratory distress in the newborn infants born through a meconium-stained amniotic fluid, okay? Whose symptoms cannot be otherwise explained, and meconium aspiration syndromes can present with varying degrees of severity, from mild respiratory distress to life-threatening conditions or life-threatening respiratory failure, okay? So the pathophysiology in this condition involves an intrauterine passage of meconium into the amniotic fluid. In all of the delivery, the burns that we could have, we could have a meconium stain of amniotic fluid in 10 to 50%, okay? And in this 10 to 50% of meconium stain of amniotic fluid, 5% will develop meconium aspiration syndrome. So this is very important. Why? Because not all of our newborns that present meconium stain of amniotic fluid will present meconium aspiration syndrome, okay? Only the 5%. And of this 5%, the 3% will need mechanical ventilation. And of this 30%, 3 to 5% unfortunately will die, okay? What are the risk factors to present this condition? The risk factors is a post-term infant that is defined by a gestational age above 41 weeks of gestation, a vaginal breech delivery, a cesarean delivery, non-resorption fetal heart rate, low Apgar scores, and need for resuscitation, and intrauterine growth restriction. This is very important. A newborn with an intrauterine growth restriction could have meconium aspiration syndrome, okay? So as I was saying to you, the pathophysiology of meconium aspiration involves this intrauterine stress that's gonna provoke a passage of meconium into the amniotic fluid, which the infants will aspirate, okay? So fetal stress may result in meconium passage due to increased peristalsis and resection of the anal sphincter from increased vagal outflow associated with umbilical cord compression or increase in sympathetic inflow during hypoxia. So when meconium has penetrated below the vocal cords, can occur an obstruction, okay? So I put you over here an algorithm to understand the physiopathology of this condition. We have meconium in the tracheobronchial tree, and it's gonna provoke an airway obstruction, air belt block, that's gonna provoke ventilation perfusion mismatch. So also the newborn is gonna present inflammation of the lungs, surfactant inactivation that could present atelectasis to ventilation perfusion mismatch, hypoxemia, acidosis, okay? So as I was saying to you, it's gonna provoke this partial or total occlusion of the airway. So the results will be atelectasis, again, in the distal to the areas of total occlusion of gas trapping with alveolar distension, okay? And what are we gonna have in our newborns? We're gonna have a history, obviously, of meconium stained amniotic fluid or physical evidence of meconium staging on examination of the infant, okay? The bare mix, the umbilical cord, as we can see in these pictures, and nails may be meconium stained too, depending upon how long the infant has been exposed in utero, okay? In general, nails will become stained after 6 hours, bare mix after 12 to 40 hours of exposure, and our neonates also will present or could present perinatal asphyxia and fetal growth restriction and post-maturity, okay? You need to always remember this. Our newborns gonna present fetal growth restriction as post-maturity, okay? These are our main risk factors in this disorder. So, again, very important, the chest X-ray in these neonates. And we're gonna see in these neonates is a progressive changes over the course of the disease. This is why it's very important to identify because of this progressive disorder. So the initial chest film may show streaky, linear densities, similar to the appearance of transitachypnea of the newborn. As the disease progresses, the lungs typically appear hyperinflated with flattening of the diaphragms too. The fused patch densities may alternate with areas of expansion. In infants with severe disease who require high concentration of supplementary oxygens and mechanical ventilation, the lungs may develop an appearance of homogeneous density similar to the respiratory distress syndrome. So this is the importance of these chest X-rays to make the differential diagnosis, okay? Because of these progressive patterns that they have. So what you need to know and to remember is this: a diffuse patch densities alternating with areas of expansion, okay? It's our main clue, our main keyword in these newborns, okay? So it's gonna see like this, okay? A diffuse patchy alternating with these density areas of expansion. This is our typical chest X-ray in the meconium aspiration syndrome, okay? So very important because many people ask this and likes to ask this, and you will present in these newborns, newborn with meconium stain amniotic fluid, but you not need to routinely use endotracheal intubation and suction for any newborn infant with meconium syndrome aspiration, okay? So if your newborn has a good tone, has a good respiratory rate, he's crying, but has meconium in all of his body, you don't need to intubate. You only need to intubate the severe cases, okay? In case of your newborn hasn't made her first inspiration, he's not crying, he's not a good tone, okay? So in a really quick summarized way, the treatment in this condition in meconium aspiration syndromes, it's gonna be, if we have a mild to moderate disease, it's gonna need our newborn oxygen hood or nasal cannula only, okay? But if we have a severe disease, we're gonna need plenty of measures: CPAP, mechanical ventilation, surfactant therapy, inhalated nitric oxide, etc. Okay, so the main goal in this newborn is to maintain an adequate oxygen ventilation. And a very important thing in these neonates is the cultures and the empiric antibiotics, okay? Why? Because it's difficult to differentiate meconium aspiration syndrome from pneumonia. So blood cultures and, if possible, tracheal aspirate cultures are obtained. And empiric antibiotic therapy start with awaiting cultures, okay? So the main complication in this newborns, and you need to remember this, is that they could present persistent pulmonary hypertension of the newborn, okay? That was one of the questions that you failed. So to finish with, we have, I think, 6 questions to know our winner this night, okay? So get ready. You have 10 seconds for each one, so. Okay. LG still winning. Next question. You only have 10 seconds, remember? So be fast. Okay, 10 seconds. Get ready. Okay, now. 9, 8, 7, 6, 5, 4, 3, 2, 1. Okay. Jasmine just have a scale to number 2 position. The next question is, what will be the most likely imagined diagnosis? Answer really quick, you have 5 seconds left. Okay. OG is still winning. We have Jasmine in 2nd place and Pablo in 3rd place. The next one, what will be the most likely imagined diagnosis? Perfect. So LG is still winning, Jasmine, and Jeremy just scaled to number 3. I think is the last one. What would be the most likely imagined diagnosis? Now, very careful with this imaging. Okay. This imaging has a sinusitis, okay? So we have our podium over here. We have LG in 1st place, Jasmine in 2nd place, and Jeremy in 3rd place, okay? Congratulations. It's all for today, guys. This is my references, and it's all for today. If you have any questions, go ahead.
Thank you so much, doctor. I don't know, guys, if you have any question, or you can write it down. You can open your microphone, please. So, thank you. Any question, guys? I have one question. Maria has a question. Do you want to open your microphone, or do you want to write it down? Maria, or you wasn't gonna ask anything? No, everybody. I can kind of have a question because I didn't see it. Doctor, if you wanna check it, you have one question in the chat.
Okay. You're asking, do we have to aspirate secretion in all newborns? No. In the hospital, routinely, we all aspirate secretion in the newborns but the thing is that they really don't need it, okay? The new guide says that aspirations in the newborns is not routinely, okay? Only you hear secretions on her mouth, secretion on her nose, on his nose or her nose, you need to aspirate. If not, don't, okay?
Okay, thank you so much. Anyone? While you are thinking about the next question, I have a question about nutrition because that's my specialty. What about the feeding of the newborn? For example, in this stress of the respiratory distress, they can continue about breastfeeding, or what is the suggestion in these cases?
Okay, it's a really nice question. Um, even in the guide said that it's because this is why it's very important, the Silverman scale. For example, in the transient tachypnea of the newborn, it's really specify the parameters, okay? If you have a Silverman scale below 2, you don't need to make some like, don't give food to the newborn. You should be able to give food, usually like breastfeeding or anything, okay? The other thing that it influence very much is the respiratory rate. Okay, so if you have in your newborn a respiratory rate below 16, you don't need to take out the food from the newborn. You're able to give them the breastfeeding. So it's gonna be really specific parameters, especially in pediatrics, like the respiratory rate, like the Silverman scale, and the most important, the clinical appearance of the newborn.
Okay, thank you. And continue about this question about nutrition and this area. What are the expectations of these newborns that have this disease about the growth they can have? They have a normal growth, they have deficits, I don't know. What's the expectation with?
It's a great expectation. Usually they don't have problems in the growing. The expectation is in the moment, okay? Like transient tachypnea of the newborn is a self-limited condition, and they usually don't have problems of growing, of mental disorders, difficulty in language, in learning, in gaining weight. Usually the respiratory disorder doesn't involve this problem with the gain weighting. It's a great scenario.
Okay. And finally, if you don't mind, because this is not my area, that's why I have a lot of questions, is which one would be your suggestion for the mothers? What can we have, like, of what kind of observation we have to have in the mothers so we cannot have these problems when the newborns?
Okay, mainly in this condition, because if it's on the newborns, the mainly advertisement, the mainly advice I can give you is to have prenatal control, okay? Because all of this, it's gonna prevent with prenatal control. For example, in aspiration meconium syndrome, it seems more frequently in newborns with weight above 4 kilograms, or in mothers that are like 41 weeks of gestation that doesn't get prenatal control, mothers that are asthmatics and doesn't have a great control, even if in the mothers that are giving her child by cesarean, to have all of this prenatal control, all of this care with your medical, because all of this is gonna prevent, okay? You can make some measures to prevent, like the antenatal corticosteroid therapy, to talk about with your doctor of these conditions.
Okay, thank you so much. Doctor, we have some messages in the chat and almost are about congratulations about your presentation. It was a very informative and interesting conference. So everybody's thanking so much for being here. And there's another question for Mariana. Which are the most common long-term sequel of respiratory disease?
Can you repeat me again the question, please?
Yes, you can watch it if you want to.
Okay.
in the chat is almost the last. Mariana. Hi, Rachel. Which are the most common?
Okay, I mean, I think she means common, no? Common long-term sequelae of respiratory diseases. Okay, the most common long-term sequelae, it's gonna be problems with fatigue in the newborns, but usually it resolves really well. It doesn't have like complications in long term. The complication in these newborns is in short term, okay? The newborns that need the ventilation could have pneumonias associated with the ventilation, but in long term, it's not really much complications.
Okay, thank you so much. I don't know if anyone has another question. Do you want to say something? Everybody's really pleased about the presentation.
Thank you,
I
Yasmin,
think they're happy.
for your best of luck in the norm. Hopefully I will enter on September.
You will. And I think this was a very dynamic conference. This webinar was really dynamic, and I think it was really useful because some of the questions, I think, for the period that you are before the national is gonna be questions that you can have in this kind of exams, right? So thank you so much. And we're really happy that we had you here. And I hope you can join us the next semester with another webinar when you rotating for another, for some next hospital.
Yeah, hopefully I will.
All right. So thank you so much. I think that's it for tonight. Don't forget that tomorrow is going to be our webinar in Spanish, our disciplinary topics, and tomorrow is going to be a chronic renal disease. I think it's going to be with the Dr. Laura, I forgot the last name, Laura Cortez, I think it is, and is one of the greatest doctor about this topic, about renal topics. So thank you so much for being here, guys. I hope you got a great night. You have a great dinner. It's already time. So thank you, Doctora. It was a pleasure to have you here. It was a pleasure to meet you.
Thank you.
So good night, everybody. Goodbye.
Good night. Thank you, guys.